So now is for everyone's favorite part of UNIGHT, and that is the disclaimer statement. So bear with me. Our UNIGHT virtual forum is educational and supportive in nature and will offer self-care strategies to help you in your daily life. However, the group will not engage in rendering any psychological or healthcare advice for any particular individual or situation and will not provide medical, mental health, or any other type of health related service. No diagnosis, treatment recommendations, medication advice, or any other type of medical or mental health recommendations will be offered. Our support group is not a substitute for or alternative to treatment by a licensed medical professional. Always seek the advice of your own physician or another qualified health provider with any questions you may have regarding your medical condition. The Hypersomnia Foundation does not recommend or endorse any specific tests, physicians, lawyers, legal advisors, products, medications, procedures, opinions, or other information that may be referenced on its website or during any online support groups. So, with that said, it is my absolute pleasure to introduce Dr. Vikas Jain. He's board certified in sleep medicine, family medicine, obesity medicine, and clinical informatics. This comprehensive training allows him to address sleep disorders alongside related conditions that affect overall health and well-being. Dr. Jain completed his sleep medicine fellowship at Stanford University School of Medicine. His medical training enables him to diagnose and treat the full spectrum of sleep disorders using evidence-based approaches from behavioral therapies to advanced medical and surgical treatments. Dr. Jain serves as a key opinion leader and national speaker for Eli Lilly, Avadel, I think now Alkermes, and Oxa, where he educates physicians on emerging sleep therapies. He also serves as a consultant to the American Academy of Sleep Medicine and is one of two CPT advisors for the AASM to the AMA, contributing to the development of clinical practice standards in sleep medicine. So, with that, is my absolute pleasure to introduce Dr. Jain and to pass the ball to him. This was a topic that I was very excited to get put on the schedule. It's something that comes up at virtually every session that we have, and that is the challenge with kind of the diagnostic process. So with that, I am passing the ball to you, Dr. Jain, and look forward to you sharing just as kind of a over piece. Please keep your microphones on mute. There will be a Q&A session at the end. If you do have questions that come up, don't hesitate to put those in the chat. So pass it to you.
Absolutely. Thank you so much. I just want to thank Hypersomnia Foundation for having me tonight. This is pretty exciting for me to be a part of this. I've been treating patients with central disorders of hypersomnolence for about 15 years now. Every year, I think I get more passionate about it than the year prior, and have even had someone in my own family diagnosed recently. So probably even more passionate than I was in the past, because sometimes it's, you sort of, when it's interesting that once you have someone that you know that has one of these conditions, the perspective that you get on some of these things really changes than kind of how you think about it just as a clinician who has no perspective on what these conditions really are. So I want to share a little bit about both of these things, but I was asked to speak about kind of how we diagnose central disorders of hypersomnolence, what to expect, what can make the testing tricky, and just things you might want to keep in mind as you sort of go through this process as well. And so one is just kind of understanding what are central disorders of hypersomnolence. These are generally a group of brain-based sleep conditions where generally excessive daytime sleepiness is present almost every day for at least 3 months. And this sleepiness is usually caused by, the brain sleep-wake system. It's not just like a poor night's sleep. It's not just a mixed up body clock. It's simply not just getting enough sleep. And so if you live with this, I think a lot of times patients, you're just tired, you're not sleeping enough. If you're sleeping 6 hours, get 7. I was thinking it's interesting, right? Like even just recently, they're like, there's a new U-shaped curve that they just released that says it's 6.4 to 7 plus some hours. And so, if you're already getting 6.5, you're probably getting enough sleep. You should be awake and alert. So someone saying to get 7 or 8 maybe is not as realistic. And so I think, you do deserve to be taken seriously because the sleepiness itself is part of the condition. And so we do have kind of 4 main diagnoses that tend to live within this framework. Type 1 narcolepsy is those who have sleepiness with sudden, muscle weakness like cataplexy. They can have low hypocretin orexin levels, which is a brain chemical that helps to keep you awake. We know type 2 narcolepsy is those who have sleepiness without cataplexy, so they may have kind of either normal or dysfunctioning hypocretin receptors or levels. And then idiopathic hypersomnia is patients who have very strong sleepiness. They're often very long sleepers that still don't quite feel refreshed. The way I like to describe it is like, I know how I feel when I stay up super late, wake up for a 4 a.m. flight, and I feel like garbage. And that's with me just having a short amount of sleep. I feel like, a lot of these patients, they can sleep all they want. They just never feel refreshed, like they can catch up on their sleep. And then Klein-Levin syndrome, which is even, I would say, more rare. I've probably only seen maybe like one case thus far in 15 years. But these are these episodes of kind of waxing and waning episodes where you get like intense, heavy sleepiness, along with changes in behavior and thinking. And then you could have sort of normal periods in between where it kind of goes away as well. And there's definitely a daily impact of these conditions. It can impact your memory, focus, mental speed. We know it can make driving riskier. And unfortunately, it can take a long time for these symptoms to be recognized and diagnosed. I'm sure, many of you in this chat, I don't know how long it took to get to diagnosis, but many patients it can be 7-10 years plus before they actually get to the diagnosis. And part of the challenge is a lot of these conditions look similar. Patients feel sleepy during the day. They can report brain fog. They can have trouble staying awake or alert, and that can happen really with type 1 narcolepsy, type 2 narcolepsy, idiopathic hypersomnia. There are mood conditions that sometimes get confused for these conditions as well. That can be why patients can spend years without a clear answer. And so really kind of if that's you, that's really where we want to kind of consider how we might check for these conditions, what kind of tests we have, and kind of just making sure you also understand how these tests work as well. So I would say the standard sleep testing path, in my experience, is, everybody gets sent for a sleep apnea test, right? And so if you show up to the sleep lab or sleep clinic, you say you're struggling to stay awake, and usually they're going to have you do an overnight study. And I think what's frustrating for me is I see this very often is sometimes patients will have a normal sleep test, and they say, well, you don't have sleep apnea, so I guess you don't have a sleep disorder. Or vice versa. If you do have sleep apnea, they might treat your sleep apnea and then say, well, we treated your sleep apnea, so it's probably not a sleep disorder. And so we do have this separate daytime nap study called a mean in multiple sleep latency test. That is a separate additional test that has to be ordered, but oftentimes it's not always ordered automatically. And so it may be helpful because that test is really what helps us to evaluate for narcolepsy and idiopathic hypersomnia. And so if you've only had an overnight sleep study, you still feel exhausted, I think it is okay to ask, should I have this multiple sleep latency test done, or can you refer me to someone who knows what that is, so that they can make sure that this is done in an appropriate manner. Because a lot of patients often go a long time, years without getting an MSLT because no one ever ordered it in the past. And that's always a little surprising. I mean, definitely I can understand. I mean, sometimes like patients with IH, narcolepsy type 2, but I've had patients in their 40s with classic narcolepsy type 1 that I've literally stared at and said, there's no way no one has ever ordered this test for you, right? And they're like, what do you mean? I'm like, I'm pretty sure I'm going to change your life because it's like impossible for it almost to not be this condition, right? And yet we miss it. And so, and again, I think it's just, doctors are kind of trained to look for sleep apnea, but there's not a lot of physicians out there that necessarily have training in looking for these central disorders of hypersomnolence. And so I think it's just important, to kind of empower yourself and don't be shy to ask, like, could these be symptoms of narcolepsy or IH? Should I have this additional test? If my overnight study was normal, what else could explain why I'm still feeling so exhausted? And then also just, is there a sleep specialist who focuses on hypersomnia in my area that I could see? And this is really where I also think like attending Conferences like Beyond Sleepy, et cetera, can be great resources. I had a patient today who came to see me, and I asked him, how many people do you know that have narcolepsy? I was like, I bet the answer is zero, right? And then I asked him, how many people do you think I know who have narcolepsy? I said several hundred, right? And I said, so, I'm happy to answer any question that you think, you may not know the answer to, because now you have a resource that you may not have had a resource for prior to. And so that can be really helpful. Um, and so again, really, what is that overnight sleep test for? It's really not to look for hypersomnia. It's usually to look for other conditions that can disrupt your sleep. Do you have sleep apnea? Do you have like leg-related movements, restless legs, periodic limb movements? Do we see that you're just like not able to maintain, sleep well, or you have like really poor insomnia, like a long sleep latency, very fragmented sleep through the night? So it kind of helps us rule out if there's other conditions that might need to be addressed as well. It also gives us a sense of just how long did you sleep? How well is your sleep organized? And sometimes we can see how quickly you go into REM sleep or dream sleep, even on that overnight study. And then we also want to make sure, are you getting at least 6 hours of sleep? Because that's really, we want to see that you slept at least 6 hours on that overnight test for the next day study to be considered reliable. And so again, it kind of helps to rule things out, but it's not to diagnose narcolepsy or IH on its own. And just because the overnight study is normal, it doesn't mean that your symptoms aren't real. It just means that sleep apnea isn't the cause. And that's really where we want to consider doing some additional testing, where you come in for another overnight test followed by that multiple sleep latency test. The multiple sleep latency test is a daytime nap study. You get 5 opportunities to take a nap in a sleep lab, and these are offered basically 2 hours apart. And what's interesting about this test to me is I had a family member just recently do this test. And to me, I've always considered this test, what a great opportunity. I get a chance to take 5 naps during the day. I would love the chance to take 5 naps, And when she did the test, she was like, this is the worst test I've ever had to do. It is like, I feel like I'm in a United States torture camp. And I said, what do you mean? And she was like, every chance I get to sleep, you wake me up and force me to stay awake for 2 hours prior to the next test, And I was like, I never thought about it that way, right? Yeah, like I can understand now. It can be really hard to stay awake in between those tasks. You're in a really like quiet, dark room, which great. Like we want it to be conducive for sleep, but also like how hard is it to stay awake between those naps when there's not a lot of stimulation going on in that environment. The nap usually ends 20 minutes after you don't fall asleep. And then, we have you kind of hooked up to our sleep equipment so that we can monitor and see what's going on. And then generally what we try to do is we look at what is your mean sleep latency. So sleep latency is how long it takes to fall asleep on each nap. And we take the average of that time. And if the average time is considered 8 minutes or less, that can support a diagnosis of narcolepsy or IH, et cetera. But this number is helpful. It doesn't always tell the full story. And I think it's also important to let your doctors know if anything might have influenced how you slept during the MSLT. I had a patient who the sleep tech walked in on the second nap and said, well, I guess you didn't sleep that nap, huh? And so then she locked herself in the bathroom, started crying because she felt like she had screwed up the whole test, right? And basically I reamed out that sleep lab and said, we're going to redo this test. And it's nobody's business to tell the patient whether they fell asleep or not, because especially not during the test, right? Like the whole point is that you should just get through the test, and then we want to kind of evaluate how you're doing and give you kind of what your results are after. When she repeated the test the second time, like she ended up meeting the diagnosis. So it's helpful to speak up and let your providers know, because we can't advocate for you if we don't know what happened during the test as well. Um, Another thing that we look for is not just how quickly you fall asleep, but how quickly you might enter REM sleep. Generally, patients enter, we enter REM sleep in about 90 to 120 minutes, an hour and a half to 2 hours. So if you enter REM sleep within 15 minutes, that's considered a sleep onset REM period or a SOREM. And so generally we try to count up, did you have SOREMs across those naps? If you had two or more, that can help support the diagnosis of narcolepsy. If you had fewer than two, it might help differentiate idiopathic hypersomnia from narcolepsy. And then generally, SOREMs tend to be more rare for patients who are not sleep deprived. So again, sometimes if we don't see any, although I would say like IH, we can see zero SOREMs as well. And that's more of just how quickly did you fall asleep? Was your mean sleep latency less than 8 minutes or not? Um, Narcolepsy type 1, in addition to seeing did you fall asleep in under 8 minutes, did you have two or more SOREMs? Generally, we want to get, is there some history of cataplexy, this sudden weakness triggered by emotions like laughter or surprise? When it, kind of clearly fits this pattern, it strongly points to a type 1 narcolepsy diagnosis. Some individuals may have even had their CSF. If you had a spinal tap, we can check for hypocretin levels or orexin levels. And generally, those levels tend to be very low. That can also confirm narcolepsy type 1 as well, although I would say like logistically, it's a little harder to get a CSF hypocretin test these days because I think only Mayo Clinic that I'm aware of currently does it. There are also some genetic markers that can be helpful clues, but not necessarily create a diagnosis. HLA DQB10602 is a genetic marker that's often linked to narcolepsy type 1. So it shows up in many patients with narcolepsy type 1, but I would say, there's a good portion of the general population that can also be positive for this marker. So it doesn't automatically mean that you may have narcolepsy, but it might point towards possibly a type 1 possibility as well. Some things that can help us get ready for our MSLT. One, again, this is a nap test in a sleep lab. So just making sure that you're getting enough sleep prior to your test, or at least keeping a regular sleep schedule can be really helpful. Because even the best nap test isn't going to give a fair result if you've been running on 3 hours of sleep the whole week leading up to your test. Some labs may have you do like actigraphy or sleep tracking to really get a sense of just sort of how regular are you keeping your sleep schedule? Are you having a really irregular sleep schedule? Because that might in and of itself explain why some patients might be more or less sleepy, right? We want to try to kind of standardize, no, I've been on kind of a pretty consistent schedule and I'm still really feeling excessively sleepy throughout the day. Sometimes some labs can also use things like sleep logs as well. These can be helpful, but sometimes they make sleep look a little bit longer because this is more of you reporting how long you felt you slept versus like maybe a watch or something, maybe being a little more objective kind of day to day on what that looks like. You may be asked to do a urine drug screen as well, because that can sometimes look for medicines or substances that might also contribute to excessive sleepiness as well. But these are not always available or always possible. I would even argue like I don't really ask for a lot of these in my own practice anymore. But they can sometimes be helpful in certain situations as well. The other things too is like, sometimes we may ask for like a medication break before the nap study. But this is not always possible. Some patients can, the reason we try to avoid these medicines is we know like antidepressants can sometimes reduce REM sleep. If you abruptly stop them and then do a test, you might get some REM rebound. Also, if you're still on those medicines, it might keep you from having a SOREM, so it might sort of influence the outcome of the test. If you're on stimulants, those might help you manage that sleepiness during the day a little bit. So you might make you look less sleepy than you truly are if you're on those medicines too close to your test as well. So usually what we're after is like a break of about 14 days or maybe 5 half-lives of the drug, whichever is longer. But if it's stopping, it wouldn't be safe. It's important, again, to let your provider know that. And I always like to tell patients too, like, I don't try to rush you into when you're going to do your MSLT, right? I understand, like, you're going to potentially need to stop your stimulant for 2 weeks prior to this test. That's not going to be a fun 2 weeks. Sometimes it's helpful to like plan ahead and say, when does my schedule going to allow for me to potentially do this a little bit better? So that you don't feel like you're sort of rushing into doing the test as well. Um, and again, I would say, like there are situations where washing out isn't safe. I tend to see this a lot with patients on antidepressants, because sometimes we worry about kind of withdrawal symptoms or thoughts of self-harm. Sometimes tapering these drugs can take 8+ weeks or longer, and that may not really always be feasible as well. And so, yeah, best case scenario might be off of medication, but just, we all live in the real world. I tell everybody, not everyone. It's very rare to meet a patient in the real world that meets inclusion and exclusion criteria for a clinical trial, right? Because we all live in the real world. And so sometimes staying on your medicine is better than stopping because it could be unsafe. And so we want to kind of read that test with those medications in mind. Sometimes we even consider that, like if your clinical history suggests narcolepsy and you have everything but the SORAMs on your MSLT, but you were on a REM suppressing medication. Sometimes I'll make that argument in my notes because to try to advocate for the patient as well. And then just important to make sure you get enough sleep before your test. Trying to kind of keep a regular sleep schedule. If you can aim for 7 hours of sleep each night for a week before your test, that can be helpful just to help us just make sure, hey, your sleep was fairly regular before you were coming in for that multiple sleep latency test as well. And then just knowing again, like working night shifts, changing shifts can throw off your clock. So if you are a shift worker or someone, again, maybe requesting or having your doctor write you a note to say, hey, we want a really consistent sleep schedule for a few weeks prior to this testing, can be helpful as well so that we can make sure that we're able to test you appropriately. So, there are things that the MSLT can miss. Again, main problem is MSLT is what's your sleep ability in a passive state in a boring sleep lab, right? But it's not really looking at what's our real world wake ability and our ability to maintain staying awake. I almost think that there should be some component to this test of what happens in between each nap, and if a patient has this tendency to fall asleep in between every nap opportunity, maybe that should mean something too, not just everything to be on the nap. But the point is, like, we all live in the real world. Like, you're trying to stay awake in everyday life while you're working, while you're driving, while you're holding conversations and tasks. And if you have real trouble staying alert, you could have really, a lot of trouble staying alert and still do okay on the MSLT as well. Uh, the other thing too is we know that this test is not a very reliable test. You come into the lab, you take 5 naps. I don't really know what that means, right? I mean, it tends to be somewhat consistent for patients with type 1 narcolepsy, but we don't see that there's always great test retest reliability in patients with type 2 or idiopathic hypersomnia. And so sometimes if it, wasn't positive the first time, you could always consider maybe, repeating that test to see if things may change the second time around. Just, so one test doesn't mean that you're never going to get the diagnosis if it's missed. And again, we've seen like 30 to 50% of patients with type 2 narcolepsy, 25 to 60% of patients with IH may get a different result or even a normal one on the second time compared to the first time that they do these tests. So this type of back and forth is helpful to know, so just so that, you're not dismissed by your provider. It's also important to know, sleep inertia can definitely affect test results. So sleep inertia is how long it takes to kind of get up, get going in the morning. Every person has some degree of sleep inertia. Some people, it's just 5 minutes. Some patients, it could be an hour or two. And so if you have a really hard time waking up, obviously that can have some influence on your MSLT because you might still feel kind of half asleep between the overnight study and the first nap. And so by the time you take the first nap, it might feel kind of shorter, even though you might have been sleeping a little bit longer. And then unfortunately, because we have to average the nap tests, Sometimes even one poor nap throws off the entire test, even though the other naps, you fell asleep very quickly. We do know that there are some folks that where sometimes we can have an abnormal MSLT even in a healthy individual, things like sleep debt. Like if you stayed up all night, multiple nights before this test, you probably should be pretty sleepy on an MSLT. We know, younger folks generally, when they have a little more delayed sleep phase, everybody likes to go to bed at 3 a.m. and wake up at 2 in the afternoon, like my high school daughter does. And so that person, asking them to sleep at 10 p.m. and wake up at 4, 5, 6 in the morning and then do an MSLT, it may not really be reflective of their typical sleep schedule. And then again, sometimes we can see REM rebound after stopping certain medications as well. So it's important for us to kind of get a sense of what medicines you're on. And they can also sometimes miss long sleep patterns. There are sort of long sleepers out there who need like 9 or 10 hours to feel refreshed. And that's sort of the difference between a long sleeper and an IH patient is long sleepers will feel refreshed after they get enough sleep. IH patients generally still don't, even despite long sleep. But again, if we only ask you to sleep 6 hours and then do the MSLT, it may not be an accurate reflection of your typical setting. And then also just, again, sometimes sleep labs can be an easy to fall asleep setting. Sometimes they can be not so calm, right? There are sleep labs in the middle of hospitals and alarms going off and things that can disrupt your test. So it's helpful to kind of keep that in mind as you consider kind of how well you, how your results came back on that test. Idiopathic hypersomnia specifically is more than just sleepiness. Again, as mentioned by Claire at the beginning, like we're trying to learn more about things like brain fog, thinking, sleep inertia, body symptoms. There are more aspects to this condition than just sleeping a lot, and we're trying to understand more about that. We're trying to understand more about sleep inertia. I really think this is helpful to tell providers. Like it takes me, 30 minutes to several hours to wake up. I have to use several alarms to wake up. These are like red flags to us to say, oh my, for at least in my clinic and the providers we have, it's like, this is IH until proven otherwise. We want to keep that on our differential diagnosis. And also just like if there's brain fog, not just being tired, but hard to focus, memory trouble, finding words throughout the day, slower speaking, these things can be very common in these conditions. And again, this long sleep pattern, 11 or more hours in a 24-hour period, we see that this is often common. I always like to ask, not just what's your bedtime, wake time during the work week, what would you do on a weekend? What would you do if you were on vacation? How much time would you spend sleeping, right? Because sometimes that can be more reflective of really like I'm sleeping 12 hours when I get the opportunity to do so. There's some lump or split debate on sort of the future of some of these things. I think I'm excited for 2027. We'll see what that brings. I'm not as liberty to say as many things, but I hope we're going to be in a position where we can do more 24-hour sleep evaluations and have patients potentially take home a PSG for a longer period of time. So we can capture kind of how much you're sleeping in a 24-hour period rather than just in our sleep schedule at the sleep lab. Most patients don't sleep exactly at 11 o'clock and wake up at 6 a.m. This might give us a much better picture of sort of what your sleep is looking like. And then the other thing is I think that these diagnoses are confusing, right? I mean, we just have sort of the MSLT, really broadly speaking, to help categorize these conditions. But these can be conditions that are hard to tell apart in daily life. Should these conditions be combined? Would it make those treatment choices easier to understand if they were combined? If you have two conditions that look and behave similarly, would it make sense to call them one thing? I tend to have the other opinion, and I think that they should be split, right? I think we don't really know what any of these things are other than, I think Dr. Mignot has helped provide us some good insights into type 1 narcolepsy, but What's type 2? What's IH? Are there subdivisions of these conditions? And is that why some patients do really well with this medicine and it seems like other patients do really well with another medicine? And what could we do more to kind of recognize, where these distinctions are, because it might help us manage these conditions better over time. So this is really where not just looking at a single cutoff, we want to look at what does your MSLT tell us, what's your full sleep story tell us, and really what's your real world experience like, because that's going to help guide how we, diagnose these conditions. I'm a big fan of Claude. I don't know if you guys are or not, but AI in sleep scoring, I think that this can be exciting as well. I've been working really hard on a sleep scorer with AI, and what's been the most frustrating thing is that AI is really good and humans not so much. And you almost have to make the AI perform worse so that it can perform as good as a human. And I think if at some point we can just say, hey, let's just have a standard, right? And have AI look at these conditions, we might get more consistent results at scale for patients across, a wider spectrum across the country. There's things like hypnodensity where we can look at 30-second chunks of sleep. AI can pick up things that we can't even see with the human eye in terms of tiny sleep disruptions, shaky boundaries. It may be able to help diagnose some of these patterns from even a one-night sleep test that we haven't been able to, see ourselves. And is it possible to even have computers go back and look through and maybe help identify some of these patients that weren't diagnosed in the past as well? I think we're having more and more wearables that are giving us more insights into sleep. And thus far, I feel like, they've kind of just been like, here's how much you sleep, here's how much deep sleep, etc. But what would be interesting is like, what's your sleep latency? How quickly are you falling asleep? Are you having SOREMs? Are these things that maybe a sleep tracker could say, hey, you may be at some risk here? Um, or hey, I kind of felt like during the day you had some moments where you may have briefly fell asleep. Could that be a warning to go get this, examined or evaluated by another sleep professional? And so again, just, again, I just want to reiterate, like, single test doesn't tell the whole story, but just make sure that you're sharing how you feel, how long it's been happening. I'm hoping with, sleep testing, in addition to that, just overnight test, advocate for MSLTs, maybe even look to see if is it possible to do a 24-hour PSG and get some sense of what kind of tools your centers are using to also understand sleep patterns over time. And then just making sure, again, that you kind of prepare for these tests, share what medicines you're taking, describe your symptoms, making sure that you mention things like cataplexy, hypnagogic hallucinations, sleep inertia, brain fog, like, just if you just say you're just sleepy, sometimes maybe that symptom in and of itself may not help that provider kind of go down this central disorders of hypersomnia pathway. And so just making sure, record things, explain things, ask for copies of your sleep tests. Again, I can't tell you the number of patients I've seen with positive multiple sleep latency tests that came to me because they were told, well, I was told I didn't have anything. And I'm staring at your test like, that's impossible because this test says you have something. So like, how is that possible? And so if you bring that copy, it can be helpful as well. So and just a message again, to me, living with these conditions can be exhausting. It can be lonely. Many patients spend years being unsure, unheard, told the symptoms are just in your head and your experience is real. I think it's great that you can be parts of groups like this where you can learn from others, learn from other patients, families, researchers, care teams. That's what helps us close the gap and help you live a better life. And so happy to take questions. Appreciate you taking some time to hear me this evening. And just want to thank Hypersomnia Foundation again.
Yeah. So, Dr. Jain, before we get into the questions, I just want to ask you where your hard stop is, because I feel like we'll probably have some good questions, but just wanted to be considerate of what time you have. So, do you want would 10 minutes be okay?
Yeah, I have no hard stop. I
Okay.
mean, we're
Okay.
fine.
All
Yeah.
right. Well, I also want to give you a compliment because I normally come with like 7 or 8 questions to ask, and I you actually knocked out like 7 of the 8 questions that I was bringing to the table, and I don't think that's ever happened. So I really appreciate the comprehensive view that you brought. I even included like some that maybe gotcha style, but I do think there'll be plenty of comments here coming up. But I was really excited to hear you talk about the extended PSG, as a potential, you know diagnostic tool down the road. But I'm going to pass it to our audience so that they can get started with some questions here. So Shelly, would you like to pitch one?
Yeah. So if you get 15 minutes to go into REM, to see if it's narcolepsy during the nap test, would that mean that whatever time someone falls asleep, like if I fall asleep at the 3 minute mark or the 5 minute mark, that I would then have a full 15 minutes before they woke me up to see if I go into REM?
Correct.
Okay. I guess I have kind of a follow-up question of that you might not have an answer to. But obviously insurance isn't down for paying for multiple tests. If I have my sleep study that says that my nap only lasted 11 minutes or 12 minutes or something, like, is there a way to advocate for, hey, my brain wasn't given enough time to go into REM during this? Or like is there kind of anything, I guess, that you can do after the fact with your doctor?
So, so I think that's a little difficult, right? I mean, I think we try to advocate for, I mean, I don't think I can make you have REM that you didn't have, right? Because like that's hard to say, like, how can I say, because I don't know if you would or wouldn't. Sometimes we can advocate for repeating the test, and depending on what the conditions are. And like again, like sometimes I've just done that with the sleep lab themselves. Like you guys didn't follow the protocol, so the patient deserves um, to do the test in conditions, the way this was intended to be done. Um, Sometimes we can make the case to insurance and see if they'll authorize you repeating that test. Sometimes I tell patients we might have to wait 4 months or 6 months, and then we can try to get this test approved again. Um, and then, so I think that there's different scenarios, and also, it might depend on, I don't know, like my perspective is sometimes how can I manage this condition for you? And, there are still tools we have to help treat IH. And from what it looks like, some more tools coming very soon, which is exciting. And so sometimes if it doesn't keep me from using the tool, I'm not always necessary. Like, I don't know that like having narcolepsy is going to make a big difference from having IH in terms of the tools I have to treat it. So sometimes we'll have that discussion with the patient to decide maybe what's the best way forward.
Cool, thank you.
Mhm.
So before I pass it to Odelia, I just want to say thank you for the example that you're setting in terms of fighting for like repeat testing if there was a hiccup during the test. I feel like it's so encouraging to hear a physician just come out and just say that bluntly, that sometimes a lab may miss on something. And so just huge credit to you for standing up for patients in that regard. That does mean a lot. So Odelia, question to you.
Yes. So I don't know if this is the right place to ask this, but um, like for me, my onset to diagnosis was 15 years, and I know that a lot of people have that thing. In your opinion, if you could change the world or whatever, what would be the first like intervention that you think would make the most impact in getting that onset to diagnosis down?
Oh, I think doctors don't order MSLTs. I think uh, I am extremely passionate to pharmaceutical companies that you send me around to talk to doctors about a drug for a condition they don't even know how to find. How stupid, right? Right? Because if you don't even look for the condition, who's going to use the medicine, right? You have to know to look for it. You have to actually order these tests. And I don't know if, like, did you have an MSLT prior to those 15 years? Or did it take 15 years just to get an MSLT, right? I mean, that's horrible, right? Because there's opportunity to find these conditions sooner. I think docs are very quick to prescribe stimulants and wake-promoting agents before just doing the test. Just do the test first. I've heard the argument like, but I could help the patient today. And this might sound mean, but I'm like, but what's another 2 weeks? You know, you've been sleepy for the last several years. 2 weeks is not going to really, like, it'll give me a chance to actually make a diagnosis. And now I might have a ton of tools in my toolbox that I could help you with instead of just a limited number. And then the other issue is, like, that helps you enough to get by a little bit. So then you're like, oh, I don't know if I should say more. And I think even on the side of the patients, right? Like, I can understand where you might say, like, if I'm like, how are things going, Adelia? Like, oh, things are great, Dr. Jain. Like, I'm just here for my wake promoting agent refill again, right? And it's like, well, I don't want to say anything because I don't want to rock the boat, and I just want to keep getting sort of the thing that I'm getting. So sometimes it's hard for us to even know, oh, no, I'm still struggling to get through the day. I'm still struggling through all of these situations. Um, like, until I had my own family member go through this, right? I was like, and I've even had some, I would say I even had a patient last year who brought some perspective to this to me, was like, all I ask about is, have you had any cataplexy attacks? What's your Epworth sleepiness scale? I was like, then I just check those 2 boxes and we go on with our day, right? But like, I would say, like, most patients with narcolepsy, when you look at what matters to them, those things are not on that list. It's, how do I get through work? How do I get, deal with relationships? Like, it's like all of these other aspects of your day that we don't tend to ask about. So that's where I think it's, like, also helpful, like, you guys, like, advocate for yourselves and say those things, because that can also help as well.
That's great context there. And one of the reasons that I love the narcolepsy severity scale is because it asks for impact. And so not only are you speaking to symptom presentation and frequency, you're also speaking to the impact that it has. And I think that opens the door to talk about how it's impacting relationships, work, parenting. So, but I love what you said there, and kind of digging a little bit deeper. We've got a couple questions in the chat that I want to go to. And Brian, I knew that you would be coming with a question here. But just a question about the diagnosis and clinical trials. This is specific to orexin agonists. Are those with long sleep time, IH, more likely to be excluded? It seems they are more often diagnosed by greater than 11 hours total sleep time, since their MSLTs are not less than 8 minutes. For the trial's preliminary MWT, they may not have short sleep latency. So are you concerned that there is potential exclusion there with that? And then
Yeah, I mean, I think that there could be, as far as trials, because there always has to be some threshold for inclusion and exclusion. But so unfortunately, I mean, like, there could be, but there are a bunch of different companies looking at molecules to help kind of treat these conditions for a variety of different conditions. And so it may be an exclusion for one trial, but it may not be for another as well.
Wanted to ask a follow-up question a little bit about long sleep. Are your thoughts on, like, the French protocol for looking at, like, any value there, and looking at a 32-hour window of sleep to see, total sleep time there?
Yeah, I actually had a slide about that and I took it out. But
That you would have gone 8 for 8.
Gone 8 for 8.
Yeah.
Yeah. So no, I mean, I think that there's definitely value. It's like, how do we get the medical community in the United States to sort of accept doing a test like that. And that's not, I mean, as one of the CPT advisors for the AMA, it is not as easy as it sounds to get like a procedure approved on a list that can then be used, especially if it hasn't been traditionally used in the United States. That's like a multi-year process. And then you're also trying to get then individuals to use a test that they're not going to get paid for, to do often enough so that we can get paid for, which often tends to be a challenge as well. So yeah, and I do think that there's utility to some of these protocols. It's just like sometimes the hard part is like, how practical is it going to be to actually implement into daily practice?
Yeah. Kind of figured the answer may center around capitalism in terms of utilization there. Why don't we pass the ball to Odalia? She has got a question, and then probably kind of wrap up so we can break into some breakout rooms after the fact.
Yeah, so my question is, for those people that have gone through the MSLT and got a negative, I've run into a few people where I'm like, oh, have you gotten checked out for narcolepsy? And they're like, yeah, it was negative. And then it's like, well, now what do I do? And so like, I've only found like 2 people that have found like a different diagnosis after the MSLT, but like, what do you, and like, I know the repeat test can sometimes result in a positive, but what do you, like, where do you point people that have gotten like negative after seeking a narcolepsy or idiopathic hypersomnia diagnosis? Where do they turn to next?
Yeah, so I mean, I think if you look up excessive sleepiness or excessive fatigue, right, there's like thousands of disorders that exist that can cause someone to feel fatigued or excessively sleepy throughout the day. So what I like to tell, I mean, I sometimes tell patients, like, you know, what I'm trying to see is there a disorder within my wheelhouse that I can help you with? If there is, I want to tell you. If there isn't, I want to tell you, because then that might help you say, well, it's not this. Let me go to the next potential thing on the pipeline. You know, could be hormones, it could be vitamins, it could be something neurologic, it could be just something, right? So there are other specialists out there that, you know, and I'm sure they have more rare diseases that they treat that I have no idea about either. So I think that's where it's kind of helpful to tell patients, like, this doesn't mean that there's nothing wrong. It just means it's not potentially one of these conditions, at least at this point in time. And also, like, if these symptoms persist, maybe you want to come back in 6 months or another, like maybe we want to revisit doing this test. If I wasn't the one that did the test, sometimes I like to ask patients, like, well, what was your experience like, right? Or if like someone like Cheryl comes in, is like, well, they took me off of this thing and they're making me sleep all this time, you know, and I'm like, well, that sounds crazy, like, right? Like, I don't know if I would do that, or maybe I would, right? Then sometimes that also helps me decide if if I agree with that negative diagnosis or not as well. So I think that can be helpful. I mean, I'm a big proponent of, like, patients don't know where to go, right? Most sleep doctors suck, like, is my opinion. Okay. So how do we tell you who the good sleep doctor, like, I know who they are nationwide, I know who they are, right? But it's like, there's not a lot of them, unfortunately, and we're trying to get more docs to understand how to treat this. But like, how can we help patients find the right care with the right specialists? Because it's not always that easy. I'm kind of shocked sometimes by some of the numbers that you hear on some of these drugs that are more specific for these conditions and how many providers actually provide them in the United States. It's like 13%. It's not a lot. So I think all of that helps, right? Like, you helping other patients find, like, you guys helping other patients find, hey, this doc, you know, helped me get my diagnosis. Maybe it's worth getting a second opinion that can be helpful. and kind of guiding those discussions as well.
Awesome. So, Dr. Jain, I wanted to thank you so much for coming out tonight, and also offer my own services if you ever needed a patient advocate to go around and help kick butt and take names in terms of elevating, our awareness of sleep disorders. One of the questions that we get a lot in groups is what questions should I ask my sleep physician? And the biggest answer I can provide is, number one, how many PWN or PWIH does a particular HCP, and then also, are you eligible to prescribe oxybates? Because if your answer isn't a whole lot to the first question, and yes, I can prescribe oxybates to the second one, it becomes an issue if you're not willing to use all the tools in the toolbox. And someone gave you a huge compliment in the chat. I want to give it a call out, that they're a current patient. I know you can't comment on that explicitly because of HIPAA reasons, but again, have people.
I would say two quick things, right? One is, I definitely think if they don't prescribe oxybates, they're probably not worth seeing. Okay, that's my opinion. Take it for what it's worth. And then the second thing I would say is, I have treated patients with narcolepsy for 15 years. I have known my sister-in-law for 7. Okay, every time she's come to my home, she's always like, I'm gonna go take a nap. And I was always like, she just doesn't want to hang out with us. She's getting an excuse to go away. And then until this past December, when I was in a car with them in Atlanta, and my brother mentioned her sleep paralysis, he was joking about her sleep paralysis. And I said, say what you said again. And then I said, wait, do you have hypnagogic hallucinations? And I asked her the questions. Yes. Once a year, or every, no, several times a week, right? And I can't tell you how ashamed I was that I missed my own family member having a condition in front of my face, right? So if I can miss it in front of my face, think about how hard is it, right? Because she didn't know to say, I'm having sleep paralysis or I'm having these other things, right? So it wasn't apparent to me just from our, I see them once a year, 7 times, right? And now she's awake in the morning on FaceTime when it's the things that I would say, I get emotional just talking about it. And it's so recent. And even I'm I can't believe I missed that. And this is what, and I told my brother, because he was do you really think this is this? And I was like, I don't know if it is. This is what I do for a living, man. And I'm one of the only people who knows how to do this, if you have to come to my sleep lab and just do the MSLT there, right? Because I'll do it, it's free, just show up and it's done, right? And she had a 5 out of 5 SORMs. I was crying each nap because I was I can't believe this is happening in front of my eyes. So I think, as much as, again, understand these conditions, but understand how to express the condition beyond just saying you're sleepy is really helpful, because sometimes that makes it harder for even the clinicians to recognize what's going on as well.
It's a beautiful story, and I love hearing the emotion in your voice talking about it, and it shows that you both care about her care, but also broadly just helping to make an impact in the quality of life. If I know you're going to sleep, so I'm going to give a personal plug for my session at Sleep. I'm actually going to be talking about the role of parents and partners play in supporting a diagnostic process, and also understanding treatment recommendations, because my wife has played a critical part in making sure I see the spots, particularly nighttime symptoms where I have blind spots. So just kind of piggybacking off of what you just said there, sometimes a partner or a parent can play a critical role in saying, hey, look, something is actually more impactful than what the person, the patient may be experiencing. So again, thank you so much for joining us tonight. For the rest of the audience, I just want to say we're going to have about a 30-minute discussion, kind of debrief afterwards. But Dr. Jain, you are a gentleman and a scholar. Thank you so much for joining us, and I hope you have a great rest of your night.
Thank you.